Dear students, today I shall discuss something about hernia. By definition, hernia is a protrusion of a part of a viscous or a viscous through an abnormal opening of the wall that it contains. So that hernia may be an external hernia or it may be an internal hernia. So if you see, this is the abdomen, suppose, umbilicus. So most of the hernias are usually external, and some hernias are internal, like diaphragmatic hernia, like herniation through the foramen magnum, and there may be herniation of the esophagus, esophageal, which is known as the hiatus esophageal hernia. So these are the internal hernia. Most common hernias are these external hernia. Out of that, inguinal hernia is the most common one. That is the inguinal hernia. And there may be hernia, the femoral hernia. There may be obturator hernia. And there may be umbilical hernia. There may be paraumbilical hernia or infraumbilical hernia. There may be epigastric hernia, and there may be incisional hernia, postoperative incisional hernia. These are the ventral hernia, or sometimes there may be diversification of the recti, leading to formation of the hernia. These are usually occurs after nullipara patients, in a case of nullipara cases, where this linea alba is stressed and the rectus becomes separated and producing hernia. So some hernias are maybe in the just lateral to the rectus, which is known as the Spigelian hernia, and some hernia may be the lumbar hernia. So these are the usual external hernias you can come across. So out of this, both in male and female, this is the inguinal hernia is the commonest one. So in femoral hernia, it is occurs most commonly in female, but that is also in female also inguinal hernia is the commonest one, but common hernia, femoral hernia is common in case of female. So if you see the etiology or the causes of this inguinal hernia, so any sort form of hernia, the main cause is either some defect in the wall that it contains, or there may be, suppose this is the wall of the viscera, where it is surrounded by the wall. So that wall may be defected, or there may be any sort of increased pressure. So any pressure increases, that may comes out. So if there is a weakness in any part, that may come. If the pressure is increases, that may comes out through this and producing an hernia, or it may be due to the weakness itself. So this causes, weakness of this causes may be a wall, may be, these are usually due to the congenital one. Congenital causes like patent sac, that is processes, particularly in case of inguinal hernia. There may be sac, may be a congenital sac may be present here. So these are the patent sac or improper closure of the processus vaginalis, or there may be and this patent sac, or there may be some defect, congenital defect in the wall that contains. So that may be, suppose in case of umbilical hernia, there may be improper closure of the hernial scar, so leading to the umbilical hernia. Most commonly in case of female, in case of children it occurs. Or there may be some defect in the collagen defect, or there may be deficient transversalis fascia, facial defect, or there may be some ectopia vesicae, or there may be defect in the wall, congenital defect in the wall, which is known as ectopia vesicae, or there may be prune belly syndrome. Prune belly syndrome. These are usually common causes or congenital causes of inguinal hernia. So sometimes there may be this internal cause may be there, which may cause rise of pressure, increased rise of pressure. So increased rise of pressure is most commonly in case of abdominal rise of pressure is most commonly these are usually congenital, these are usually acquired. These are most common causes. The cause is the chronic cough. Chronic cough patient, in case of children it may be bronchitis or whooping cough, or in elder it may be bronchitis or that sort of things. So any obstructive pathology in the bronchioles, that is the chronic leading to chronic cough, may cause increased intra-abdominal pressure and may cause herniation through any defect or weakened part of the abdominal wall. So then there may be obstructive uropathy. That means if the outflow of the urine is obstructed by most commonly by the BEP or by the stricture urethra. So in that case also there may be the abdominal pressure will be increases, and that will be reflected into the most weakened part, and the patients may develop herniations. Or there may be chronic constipation. Or sometimes there may be some growth, or there may be fullness in the abdominal cavity due to presence of some other things. It may be due to the presence of fetus, like pregnancy. So in pregnancy also the abdominal wall becomes stressed, and it may lead to the formation of hernia. Or there may be some malignant diseases, malignant growth, or it may be due to the ascites. Any causes, anything which increases the abdominal pressure may lead to the formation of a hernia. So there may be some defect in the wall, or there may be rise of intra-abdominal pressure, or anywhere. It may be in the lungs cavity, internal hernia, or in the brain. Any pressure defect may lead to the formation of hernia. So this hernia, for development of an hernia, that means it needs a sac. So these are the external hernia. So out of this, most common hernia is the inguinal hernia. Now we shall discuss something about the inguinal hernia itself. Because of this is the most common variety, we shall go for the inguinal hernia itself. So inguinal hernia. First of all, you have to know certain things about the inguinal regions. That is the surgical anatomy. So suppose this is the abdomen, this is the inguinal ligament, this is the pubic symphysis, umbilicus. So this is the inguinal ligament, anterosuperior spine, and the pubic tubercle. So inguinal canal is lying just medial to third of this inguinal canal, usually in this region. It is around 3.75 centimeter in length, and there is a deep ring through which this spermatic cord comes out like this. So suppose this is the spermatic cord, or the round ligament in case of female. So this is the testis. So this traverses through the inguinal canal and comes out through the superficial inguinal rings. So this deep ring is situated around situated. Suppose this is the anterosuperior one and the symphysis pubis. So this is the, you have to take the midpoint of the inguinal ligament, that is you in between, this is the midpoint of the inguinal, above 1.25 centimeter, above the midpoint of the mid-inguinal point. So midpoint of the inguinal ligament and mid-inguinal point is something different. Midpoint of the inguinal ligament means inguinal ligament extends from this anterior superior spine to the pubic tubercle. That is the mid. If you take the middle point, that is the mid-inguinal point. That is the mid-inguinal point, or midpoint of the inguinal ligament. So if you take the anterior superior leg spine and the symphysis pubis, that will be the mid-inguinal point. Here you take a 1.25 centimeter above the mid-inguinal point, that will correspond with the internal ring, that is through which the spermatic cord comes out. That internal ring or the internal ring or the deep ring is an U-shaped structure which is bounded usually by the transversalis fossa, and the superficial inguinal ring is there is a defect in the external oblique aponeurosis through which the spermatic cord emerges, comes out, and this is usually bounded in the pubic tubercle. So this is there are two cross, that is one is the the two cross through which of the external oblique aponeurosis through which this spermatic cord comes out. So in this point this is the inguinal canal, around 3.75 centimeter in length. So boundaries of the boundaries of the inguinal canal, if you see from outside, the skin, subcutaneous tissues will be there. So most superficial part, that is just above the anterior to the spermic cord, you will get the external oblique aponeurosis coming out like this from here. So there you will see the like this the external oblique aponeurosis. So that will be the spermatic cord, suppose, coming out like this. So anterior part is covered by the anterior superior leg, that is the aponeurotic fibers of the external oblique muscles. So just behind the external oblique muscles, in the lateral part, that is the inguinal ligament, from the lateral two-thirds of the inguinal ligament, you can see that the internal oblique muscles are rises and goes like this, and in this region this external oblique muscles and the transversalis muscles, transversus abdomen muscles, join to form the conjoint muscles or the conjoint tendon that covers the lateral portion of the spermatic cord. That means the anterior boundary of the inguinal ligament is, inguinal canal is external oblique aponeurosis, and in the lateral side it is covered by the conjoint muscles. Then these conjoint muscles hooks around the spermatic cord and goes like this, that it becomes forming a tendinous part. In the medially it goes behind the spermatic cord. So anteriorly the anterior boundary is formed by the external oblique aponeurosis, and the lateral portion of the lateral part of the inguinal canal in the anterior boundary is formed by the whole portion is covered by the external oblique aponeurosis, and behind it by the internal oblique and the transversus abdominis it will hook around. So lateral portion will be the both by the external oblique and the conjoint muscles. So the posteriorly it is covered by the transversalis fossa and the medially by the conjoint tendon, and floor is formed by the inguinal ligament. This is the inguinal ligament. So this is the boundaries of the inguinal canal. So what is the content of the content of the inguinal canal. So content is, you can see in male it is the inguinal spermatic cord. In female it is the round ligament. And apart from this, there will be, you can see there will be two nerves will be there. One is the ilioinguinal nerve, another is the genital branch of the genitofemoral nerves. See this ilioinguinal nerve has some importance here. So sometimes these patients during appendicectomy operations, here you will get, for appendicectomy you usually make an incision in the McBurney's point. So particularly in a muscle cutting incision of the appendicectomy procedure, sometimes these ilioinguinal nerves may be injured. That may causes weakness of these muscles and may lead to the formation of the hernia. So this ilioinguinal nerve. So during operative procedure, see the spermatic cord will be there, ilioinguinal nerve and genital branch of the genitofemoral nerves. So these nerves, while going for the treatment of the hernia, we have to preserve these two nerves. Now this is the hernia boundaries, that is the surgical anatomy of the inguinal canal. See, these are the rectus abdominis muscles, and here is the femoral artery. So from the femoral artery there is a vessel goes like this, which is known as the inferior epigastric artery. So this inferior epigastric artery has certain importance. So deep ring is just lateral to the inferior epigastric artery. And see this inferior epigastric artery and this lateral border of the rectus abdominis and this the inguinal ligament, that forms a triangle. That means this lateral border of the rectus abdominis muscle, that is inferior epigastric artery, and the inguinal ligament, that forms this triangle. This triangle is known as the Hasselbalch's triangle. So hernia, if the hernia in the inguinal region, that is inguinal hernia, comes out through this deep ring and traverse through the inguinal canal and becomes superficial through the superficial inguinal ring, that will be known as the indirect inguinal hernia. That means it will comes out along with the spermatic cord. But if the hernia comes out through this Hasselbalch's triangle, then it will be termed as the direct inguinal hernia. That means the inguinal hernia may be indirect or it may be direct. So if that means direct hernia comes out through the Hasselbalch's triangle, and the indirect hernia comes out through the deep inguinal ring, that is the internal inguinal ring or the deep inguinal ring, and becomes superficial whenever it comes out through the superficial inguinal ring. This both will be comes out through the superficial inguinal ring. See the relations of the spermatic cord with the sac. So a deep ring, that is, suppose this is the spermatic cord coming out. Suppose this is the spermatic cord comes out like this, and this is the testis. This is the, whenever during descent of this testis, along with this spermatic cord, the peritoneum will also be pulled out. This peritoneum will also be comes out. So this forms sac usually. So this is processus, which is known as the processus vaginalis, and after birth usually this sac is closed. So sometimes this sac may be patent, remain patent, and this may lead to the congenital formation of hernia. So this sac is usually lying anterior to this spermatic cord and just lateral to it. Anterior and lateral to the spermatic cord. The indirect inguinal hernia sac will be anterior and lateral to the spermatic cord. But in case of direct hernia, so this hernia, in case of direct hernia, this will directly comes out. This spermatic cord comes out over the floor. So this floor defect will be in the floor in the Hasselbalch's triangle. So that sac will be posterior to the sac, posterior to the spermatic cord. So in case of direct hernia, the sac will be posterior to the spermatic cord. See this now we shall discuss something about the sac. This sac, suppose this is the, again we will go for this. So suppose this is the sac coming out along with this, and along with the spermatic cord. This is the testis, suppose. So this portion of this peritoneum, which is remain in the abdominal cavity, becomes, and this is, suppose this is the deep inguinal ring, or whatever the superficial. So in case of Hasselbalch's triangle, this portion ring. So this portion is wide enough, and this portion is called the mouth of the sac. This is mouth of the sac. Now this most compressed part, it is the most constricted part, is known as the neck of the sac. See, neck of the sac is very important. If the neck is wide enough, just like any hernia, suppose this is a diversification of hernia. So this whole portion, this rectus will be diversified, it will be separated. That means the neck will be wide, very wide. In that case, if the neck is very wide, or just like in case of inguinal hernia also, the neck is, if the neck is wide or petulous, then the chances of complications will be less. But if the neck is very narrow or very small, if any contents comes out, it may not be unable to goes back, and that may lead to some sort of complications. Sometimes it may be most dangerous complications. So neck of the sac is very important. This is, you can, while dissecting this indirect inguinal hernia, this neck will be usually just lateral to the inferior epigastric, this inferior epigastric artery. But in case of direct inguinal hernia, this neck is, it will comes out through the Hasselbalch's triangle, so neck will be wide. That's why in case of direct inguinal hernia, the complications like obstruction or the strangulations are usually very rare. So most complications are usually occurs in the indirect inguinal hernia. So this is the neck, and this portion of the sac is known as the body of the sac. This is called body of the sac, and the most distal portion is the fundus. So in case of sac, it comprises the mouth, neck, body, and the sac. So this sac may contains what may be the content. The content of the sac. So content means, suppose this is the sac, and this is the sac, this is the neck, and this is the mouth, and this is body, fundus. So this may contain the abdominal cavity. This is any viscera, which may be the intestine, so this may be the intestine, or it may be the omentum also. it may be omentum, and this is the intestine. So if it is intestine, then it is called enterocoel. Enterocoel, or if it is omentum, then it is called omentocoel. Omentocoel or epiplocoel. See the difference clinically you can make out whether it is an enterocoel or an omentocoel. See in case of enterocoel, that is if it is contains the intestine, see if you whenever you want to reduce the hernia, the initial part will be difficult to reduce because of it will contain the intestinal contents and the gas. So initial part will be very difficult, and in the last part, whenever it goes into this region, some amount of content will be, and intestinal contents will be pushed back, and that will be immediately goes back. That means the last part of the reduction will be very easier. That means the in enterocoel, first part will be difficult. First part of reduction, that means reduction, and the last part will be easier, and that will be reduced by a gargling sound. Gargling sound because of the pushback of the gas, and that will be reduced by a gargling sound. So if you push it, the initially it will be difficult, and if you pull it, and in this, if it goes into this neck region, and immediately it may go into the peritoneal cavity, and with a gargling sound. So that will, if you feel this type of thing, then that will be known as the enterocoel. But in case of omentum, these are like this, fan-shaped pattern remains here, and these are initial part will be very easier. Whenever you reduce it, it may block it, and it will be very difficult to reduce the last part. And it is usually doughy in feeling, just like a maida, doughy in feeling. So that is known as the omentocoel. Sometimes this may contain some other things also, like it may contain, in case of ascites, it may contain fluid, or it may contain sometimes the part of the intestines. So suppose that this sac may contain a part of the intestine like this, that is a diverticulum of the intestine, Meckel's diverticulum. Suppose this is the sac, it contains part of the intestine. So a wall of the intestine, if it contains a wall of the intestine, only a wall of the intestine, which is known as the Rister's hernia. Or sometimes it may contain the appendix also, or it may contain the Meckel's diverticulum, which is known as the Litter's hernia. So these are the contents of the hernia. So if you see this hernia, so this is clinically or pathologically, you can see this hernia is usually reduced. So the hernia is two main diagnostic sign of hernia. We will discuss it later on. One is the reducibility and the impulsion cupping. So this it may usually reduce. So hernia, whenever the patient lies down, the hernia usually reduces by itself, particularly the direct inguinal hernia spontaneously reduces. So sometimes this hernia may be complicated. So the complications of hernia, so it may be mostly these are reducible, see, and sometimes it may be irreducible. Irreducible, that means that if a hernia, suppose this is the sac and these are the intestine, So this content, that is either omentum or the intestine, it may adherent to the, this is the sac, adherent to the sac by the some fibrous tissue. So this may, if this adhesion occurs by some due to some sort of inflammation or by long-standing cases, there may be some sort of inflammation, and that may adherent to each other, to the sac, or sometimes the content itself. It may adherent to each other, and that becomes irreducible. So, but in that case, there will be no any compromisations of the blood supply, neither the lumen of the intestines is obstructed. So the contents, whatever the intestinal contents coming out, it will be easily goes back through and through, and there will be no sign of any other problems. So this is irreducible. Only problem will be the hernia will not be reduced completely. So it is because of the adhesions to the sac. Sometimes what happens, the sac, whatever the content is, it becomes obstructed. Obstructed hernia. The hernia may be reducible, irreducible, obstructed. Obstructed means usually there will be an overcrowding of this intestine. Suppose the patient is having a sudden severe cough or any sort of causes where abdominal pressure increases, there may be suddenly sufficient amount of intestine or the omentum comes into the sac, and it will be filled up, and that may not be able to goes back, unable to goes back, and that if it suddenly comes out, suppose sudden overcrowding occurs, suppose the neck is, this is the end from where a sufficient amount of intestine comes out, and that will be like this. So that will unable to come back, and at the same time it will, if it is overcrowding of the intestines occur, these intestines will be unable to, this content will unable to go continuously from the, suppose this is the afferent loop and this is the efferent loop. These contents will unable to go through and through from the intestine up to the large intestine or up to the distal part. So this is usually because of the small or the narrow neck of the sac. So this causes, the sudden overcrowding causes usually the obstruction. So in obstruction, what happens, this part will be unable to reduce. The hernial content will be unable to reduce, and patient will complain of sudden increase of size, and that will be followed by the pain, and there may be, if the obstruction occurs, the contents unable to pass through, this portion will be gradually dilated. This is afferent loop. Afferent loop, and this will be the efferent loop. Efferent loop. So this proximal part will be gradually distended because of the this residual content. This content of the intestine will be unable to pass. So initially what happened, the intestines will be, intestinal peristalsis will be increased to overcome this pressure. That's why patient will have a, what will happen, patient will have a sudden, so patient complaining of sudden enlargement of the sac or the hernial content, and that will be unable to reduce, and the patient will have a colicky pain because it will be tries to overcome this obstruction. That's why there will be vigorous contraction of the proximal intestine. So that will be the patient will have a colicky pain. So if it will not be able to pass the content, this proximal part will be distended by the content as well as the gas. So patient will have gradually abdominal distension, and so if it is occurs, contents remains there, obstruction occurs, patient will have nausea and vomiting. So if you examine the peristaltic sound, you can see there will be increased peristalsis, initially increased peristalsis. So this is obstructed hernia. You can see there will be enlargement, sudden enlargement of the sac or hernia, and that will be unable to reduce. Patient will have pain, and there will be there will be gradually distension of abdomen occurs, and this is known as the obstructed hernia. So if this obstruction persists, there may be some sort of compromisations of the blood supply. Here in obstructed hernia, blood supply will not be compromised. So blood supply will be intact. Only the intestinal lumen will be compressed, and that will lead to the obstruction of the intestine. So if the blood supply is compromised, then it will be known as the strangulation. It is known as the strangulated hernia. So strangulated hernia, suppose this is the hernial sac. So this maybe comes out like this, suppose. And suppose this is the mesentery, and lots of intestines are coming here. So here, what happens in case of strangulation? This ring is, in obstruction also, ring will be usually a small ring, a narrowed ring through which a huge amount of content comes out, that is leading to overcrowding here, that will compress each other due to the overcrowding. So that leads to the compromisations of the blood supply. So this initially, due to that obstruction, this intestine will be congested. There will be congestion of the intestine, and that will compress usually the veins. Initially there will be compressions of the vein. So normally these intestines are, this intestinal wall, if you see the intestines are usually shining. Normal shining the intestines. So because of these compressions of the vein, there will be congestions of the blood vessels here. So this shiny or glistening surface of or glistening intestines become congested, or it becomes reddish in color, and this it becomes reddish in color, and if you do not treat it in proper time, these congestions will be increases. There will be this blood congestion occur. There may be transudations of the blood into the lumen, and there may be extravasation of blood into the sac also. So initial part of this obstruction, there may be transudation of fluid into this sac cavity. This sac will contain serous fluid in the initial part because of congestion of the intestine. So if it process goes on, this compromisations of the blood supply, initially the vein, the artery will pump the blood, so there will be over congestion gradually, and that there will be extravasation of blood, so this fluid becomes mixed with blood and becomes hemorrhagic. So blood comes out here, so this becomes hemorrhagic. So if this process goes on, this congestion occurs, that you will not treat it, ultimately this arterial supply will also be blocked. This artery also will be blocked. So if the artery is blocked, this part becomes, whole part becomes ischemic. If particularly the anti-mesenteric borders will be the more ischemic. There will be, because of loss of blood supply, this color of these intestines becomes. So initially this is shiny and it becomes reddish, and if the congestion goes on, it becomes reddish or purple red, or if it is ischemic, it becomes blackish or greenish, if the greenish in color. So this, if ischemia occurs, this becomes gangrenous because of loss of blood supply. The color of this intestine becomes blackish or greenish in color, and this shining will be lost. There will be fibrinous exudate will be there, and the peristaltic movement, whatever the tone of this intestines will be lost. It becomes flabby. These intestines become flabby. So this contents of this sac will be initially the serous fluid, then becomes hemorrhagic, and if it is ischemic, it becomes blackish. This RBC also become hemolyzed and becomes blackish in color. And because of the necrosis or the gangrene formation, there will be perforations. Sometimes it may lead to perforation. At the same time, there may be transmigration of the bacteria into this sac and also into the lumen of the intestine. So there will be this fluid becomes, initially it will be sterile and it becomes infected. Because of toxin of the bacteria, these fluids become very toxic. If it goes into if you do not treat it, most common site of this strangulation is at the neck, because of tight ring at the neck and at the mesenteric border. So sometimes here it may be perforate. So gangrenous formations, it may perforate, and this contents may goes into the peritoneal cavity, leading to generalized peritonitis, or from the sac also it may goes into the peritoneal cavity, into generalized peritonitis. These are the usual, that is the pathophysiology of strangulated hernia. So that needs this part may be gangrenous within 5 to 6 hours from obstruction. If a sudden obstruction occurs, may becomes gangrenous within 5 to 6 months, depending upon the size of the ring, that is the size of the neck, and the content. If the content is more, then the size is neck is smaller, then there may be more chances of necrosis within a very short period of time, usually 5 to 6 hours. That means these patients needs immediate surgical treatment. So what you will see whenever you examine this patient, what you will see? You will get all the findings of the obstruction. Apart from this, if you examine the sac, you can see it becomes tense because of the contents and the excoriated or the extravasated blood and fluids. It becomes tense and it is tender, and all other signs of inflammations will be there. Tense, tender, sac. And other things, if it is process goes on, if peritonitis develop, the intestines become whatever it initially become hyperperistaltic, it becomes adynamic. This is paralytic ileus will be developed. So treatment is very important in this case. Immediate treatment is required. So these are, you can see here up till now you have seen, one is the uncomplicated or reducible hernia, irreducible hernia, obstructed hernia, and the strangulated hernia. Sometimes another types of hernia is also described, which is known as the incarcerated hernia. Incarcerated hernia, sometimes we may mislead with just like obstructed or strangulated hernia, but in true sense it is nothing but suppose this is the sac and these are the intestine. If if this lumen of the intestine is blocked by a fecal matter, and it will not be able to reduce back into the perineal cavity, and it is blocked by this fecal matter, then it is called the incarcerated hernia. This is fecal matter or the stool. So how you can differentiate it? You see this fecal matter, if you examine it, if you press over the fecal matter, you may be able to see that there may be fecal matter may be indented. So this scavulous mass will be indented. So you will get if you press it over the fecal matter, you can find a deepening area, that is which is known as indentations. So you can, if you find it, that will be a case of incarcerated hernia. Sometimes another type of hernia is also described, which is called as inflamed hernia. Inflamed hernia is occurs due to if the content is inflamed, content of the sac is inflamed, then it is called as an inflamed hernia. It is very rare variety. Suppose if the hernia content is an appendix which is inflamed, that is acute appendicitis in the case of hernial sac may lead to the inflamed hernia. Or sometimes the diverticulum, that is Meckel's diverticulum, which is inflamed, may lead to the inflamed hernia. Similarly, salpingitis, if the content is salpins, then it may lead to the inflamed hernia. So these are the usual presentations of the hernia. Some rare hernias are also there. Some other types of hernias are also there, which are usually Rister's hernia. Rister's hernia, this is one of the surgical dilemma, where how to diagnose and what treatment you have to do it in the case of Rister's hernia. See this, in this case only a portion of the intestine may be, suppose this is the neck of the sac, a portion of the not whole circumference, a portion of the intestine, a part of the circumference of the intestine will be obstructed here. It may lead to the strangulations also. Then it is known as the Rister's hernia. This type of hernias are usually occurs most commonly in the case of femoral hernia. So here you will not get a proper swelling, just like all other types of inguinal hernia, and the content of this hernia will be able to go through and through, and patient will not have any sign of obstruction or any sign of strangulation. Patient may present it with local pain at the local site of obstruction, but these patients, because of irritations, patients may present it with just like a gastroenteritis. So there will be diagnostic dilemma. So most of the patients are usually, because of this portion of this part will be strangulated, and patients this part may be gangrenous, and patient may present it with peritonitis. So these patients are usually delayed in diagnosis and the delay in treatments also. So that's why most of the patients are usually treated or diagnosed perioperatively if the patients presented with peritonitis. So this is known as the Lister's hernia. Another is the Lister's hernia. Lister's hernia, when the hernial content will be the Meckel's diverticum. Meckel's diverticulum. Meckel's diverticulum, you know, the 2 feet away from the ileocecal junction in the ileum, and it is around 2% cases it is present, and it is around 2 inch in the length and 2 feet away from it. So in case of 2% of the patient it may be present, all 2. So this Meckel's diverticulum, if the content is Meckel's diverticulum, it is known as the Lister's hernia. And another hernia is known as the Madel's hernia. Madel's hernia. So here also known as the hernia NW. So this hernia is just like this. Suppose this is the ring. So some portion of the intestine will be in the abdominal cavity and some portion will be the intestine. So this will be just like a W type. So one portion of the intestine will be goes back into the abdominal cavity, and just like appearance of W it will be. So this here one thing is the most important thing is that here the gangrene starts first in the abdominal portion because of the most compromisations occurs here. So patient will have pain. If you examine this patient, you may get tenderness in the suprainguinal regions, and patients may present with all the signs symptoms of strangulations. So this is also here the retrograde strangulations occurs because of this portion goes into the back into the peritoneal cavity. So strangulation will be retrograde, or gangrene will be in the retrograde pattern, which is known as the Madel's hernia or hernia NW. Sometimes there may be this hernia, there may be gliding or the so suppose they are along with the, suppose this is the hernial sac, and the contents will be the something is there. Along with the wall posteriorly there may be some other intestinal peritoneal structure. Suppose the cecum may also comes out and forms the one wall of the sac. So this is known as the sliding hernia. So these are the different types of hernia you may encounter, and sometimes what happens, some other varieties, suppose these patients may be a indirect inguinal hernia, and that patients may also have direct inguinal hernia. Indirect plus direct. That means suppose this is the inguinal canal, so, and this is the inferior epigastric vessels, and this is the lateral border of the rectus muscle. This is the hernia. So, and the herniations occurs from this here, and at the same time herniation occurs from this here also. So that portion is prevented by this inferior epigastric. So that becomes a dual hernia, or it is just like a saddle separate hernia like this, or you can see a separate, sometimes separate sac like this. So this is the indirect hernia, then this is the direct hernia, and divided by the inferior epigastric artery. So this is known as the saddleback hernia or dual hernia, or it is also known as the pantaloon hernia. Or dual hernia. So many a times if you diagnose the patient as an indirect inguinal hernia, then during operations you may find that the patient is having a direct inguinal hernia also. Or sometimes there may be diagnostic dilemma. If you indirect inguinal hernia, the procedure how you have diagnosed an indirect inguinal hernia is the deep inguinal ring occlusion test. If you occlude it, and you will see that the hernia may comes out through this also. This is direct inguinal hernia. So if you can diagnose it, that is a case of direct inguinal hernia. But at the same time, patient is having an indirect inguinal hernia also. So that is known as the dual hernia or pentalon hernia or saddleback hernia or saddle-shaped hernia. So these are the different other types of hernia. Now, for diagnosis, how these are the different, you know that the different types of inguinal hernia. Now the diagnosis. Diagnosis is purely by a clinical examination, from the history and by the clinical examination. On history, patient will say that the swelling occurs in the inguinal region, gradually increasing into the size and goes into the scrotal regions and may reach the scrotum. And when the patient lies down or in the morning, the swelling may be reduced. So that means that there is a connection between the abdominal cavity and the swelling. That means that is known as the reducibility. So that means the swelling may be reduced in size or whole contents may reduce into the original site of occurrence, that is the peritoneal cavity. So if it is reducible, if a swelling is reducible or reducibility is present, then it is one of the diagnostic sign of hernia. Then another is, if you see the patient impulse on cupping. Impulse on cupping. So impulse on cupping, if it is present, then it is a case. If both, it is also diagnostic of hernia. So if both these two are present, impulse on cupping and reducibility, these are the diagnostic sign, then you can directly say this is a case of hernia because of presence of impulse on cupping and reducibility. So that is nothing but a case of hernia. There is no need of any other diagnostic investigation for confirmation of the hernia. So if sometimes these are, in some conditions this may be not possible, just like if it is complicated, like irreducibility or obstructed or strangulated. In that case, it may be sometimes very difficult to diagnose because of impulse on cupping is also absent and it is not reducible. So it is very difficult to diagnose. Then only it needs some certain investigations like ultrasonography or CT scan. So this CT scan is not needed for this external hernia like inguinal hernia also. Sometimes this may be needed for internal hernia, to diagnose an internal hernia like diaphragmatic hernia or that sort of hernia. So this is diagnostic of hernia, the impulse on cupping and reducibility. To see an impulse on cupping in a case of small hernia that is bubonosis. Oh, we have not discussed, I think, one thing. This one thing, that is the extent of hernia. We will discuss later on. So impulse on cupping, usually you should look for in a lying down position as well as in standing position. Some hernia, particularly in indirect inguinal hernia, may not be obvious on lying down position. So you have to look for in standing position also. See, some small hernia may be better seen than the field, but in large hernia you can feel it properly. But in some small hernia like bubonosis, it is better to look for to find out the impulse on cupping is present or not. See this extent of hernia. See, sometimes you have to know it properly in a case of hernia. See, if the hernia remains within the inguinal canal, it will not come out into the superficial inguinal rings, and it remains into the inguinal. Small bulge is there, you may be able to see in this inguinal regions, and that will reduce spontaneously, or this swelling, it remains into the inguinal canal. Then it is known as the bubonocele. Within the inguinal canal. So if it goes, suppose this is the anterior superior spine and this is the pubic symphysis. Suppose if goes up to the this hernia goes up to the just above the testis. This hernia goes up to the above the testis, then it will be known as the funicular or incomplete hernia. So if this hernia, if this is the testis, here you can feel the testis separately, and the hernia just above, it goes up to just above the testis, then it will be, that means it crosses the superficial inguinal ring and ends in between the testis and the superficial inguinal ring, then it will be an incomplete hernia. And sometimes this hernia may goes up to the testis. Bottom of the testis, this hernia contents may goes up to the bottom of the testis. In that case, sometimes you may not be able to feel the testis separately. So that is known as it goes up to the bottom of the scrotum or the below the testis. So this is known as the complete hernia. So you have seen that one is the bubonocele, incomplete and complete. Another something you have seen that is the whether it is complicated or uncomplicated, or you can see that is whether it is a direct or an indirect hernia. Direct or indirect hernia you have seen. So to diagnose a direct or indirect hernia, one clinical test is required, that is the deep ring occlusion test. That is, suppose this is the deep ring. If you occlude it, the deep ring, that is the with your thumb, and ask the patient to cough, if the swelling does not comes out, or the swelling is no, you can feel that impulse here in your thumb, and the swelling does not appear, then it will be a indirect inguinal hernia. That means the source through which this hernia comes out is obliterated, and that's why this hernia will not be able to come out. So that will be a indirect inguinal hernia. And you have occluded here, but the hernia occurs here, then it will be the impulse or swelling appears here, then it will be a direct inguinal hernia. That means deep ring occlusion test, if it is positive, that means that on deep ring occlusion test, if the hernia does not comes out, then it will be a indirect inguinal hernia. If hernia develops, then it will be direct inguinal hernia. Out of this all inguinal hernia, right-sided hernias are right-sided inguinal hernia is more common, because this right testis is descend later than the left. So that's why this processus vaginalis may not be completely fused in this region. So there may be failure of fusion of the processus vaginalis, and that sac is more patent on the right side than the left. That's why the right-sided hernia is more common. So this hernia may be on the right side or it may be on the left side, and sometimes it may be bilateral. Right side more common. It may be on the left side also occur, or it may be both sided hernia may be there. So this is so for the practical purpose, the indirect inguinal hernia is usually occurs within a preformed sac. If it occurs in a younger age group, that is a congenital hernia. In case of very elderly patients, if this indirect inguinal hernia occurs, but it gradually increasing in size, very gradually increasing in size, and it is not complete, a small, or it may be bubonocele or an incomplete hernia, you may say that it may be a case of acquired indirect inguinal hernia. Otherwise, for practical purpose, all indirect inguinal hernias are congenital one. So, usually for congenital indirect inguinal hernia, this should be goes up to the bottom of the scrotum. Okay. If it goes up to the bottom of the scrotum, that's all inguinal hernia, irrespective of the age, it should be labeled as a congenital hernia. Congenital hernia means congenital preformed sac will be there. Now, this one thing sometimes very difficult to differentiate, that is the femoral hernia. So, inguinal hernia comes out through this superficial inguinal ring. This is the pubic tubercle and this is the inguinal ligament. So, in case of femoral hernia, this is the femoral triangle is there. So, this is it contains the femoral artery, vein, artery, nerve, vein. Vein is more medially, artery and nerve. Just medial to the vein, there is a femoral canal through which the femoral hernia occurs. Here, like this. So, if you feel the pubic tubercle, this hernia, inguinal hernia, comes out above this pubic tubercle and medial to it. See this pubic tubercle, this is the external of the external ring, this is the medial to it, it comes out like this. That is the inguinal hernia is above and medial to the pubic tubercle. Okay, but here this femoral hernia, this is lateral and below the pubic tubercle. So it is a femoral opening is usually, and it comes out through the saphenous saphenous. This is the 4 cm lateral and below the pubic tubercle. So that means the femoral hernia is below and lateral to the pubic tubercle. Now, diagnosis is made by clinical examination, that is the presence of impulse on coughing and reducibility, and if needed, you may have to go for the ultrasonography in a complicated hernia. Now, you have seen that the hernia may be a bubonocele, incomplete or complete. It may be indirect or it may be direct. It may be uncomplicated or it may be complicated, or it may contain small intestine or it may contain the omentum most commonly. So your diagnosis will be, so first of all, whether it is an inguinal hernia or not, or femoral hernia or an obturator hernia, what types of hernia is. So it should be an inguinal hernia. First of all, it should be an inguinal hernia. And which side, right or left? If it is right, you should write it right-sided inguinal hernia. And whether it is a direct or indirect, you have to write it indirect or direct. By doing this deep ring occlusion test, you can confirm it. Then it is reducible or complicated. Whether if it is reducible, you write it reducible. So what in your diagnosis you have to write it all the things. Which side? If it is bilateral, you have to write it bilateral, or it is left side or right sided hole. Then inguinal, then indirect, reducible, and extent. Whether it is bubonocele or incomplete, it may be incomplete, or what the content is, that is the intestine or mentum. If it is intestine, then it will be a enterocele. So these 6 things you have to write down: side, which hernia, direct or indirect, whether it is reduced, there is complicated or uncomplicated. If it is complicated, you have to write it down: irreducible, obstructed, or strangulated. Then whether it is incomplete or complete, or what content it is. So we should better say it: right-sided, indirect, reducible, incomplete, inguinal hernia of enterocele type. Okay, so this will be the diagnosis. Next will be the treatment. So that part we will discuss in a later way. Okay, thank you.